All right, we're going to go ahead and get started. Good afternoon, everyone, and welcome to the Immune Deficiency Foundation's Lunch and Learn series. Today's program will explore chronic neutropenia with Dr. Jim Connelly of Vanderbilt University School of Medicine. My name is Emma Mertens, and I'm the Program Manager of Community Health at IDF. On behalf of all of us at the Immune Deficiency Foundation, I'd like to thank you for joining us today for this Lunch and Learn. We are excited to host this webinar for the IDF community. IDF is dedicated to fostering a community empowered by education. We want you to remember that IDF is committed to our community, serving you as a trusted resource through the use of technology and innovation. We are here to give you the tools and information to become empowered and offer you our compassion, understanding, and support to emphasize that you are not alone on your journey. Today's Lunch and Learn is part of IDF's regular series of bite-sized programming that will provide diagnosis-specific information and support to our community wherever they may be. Today's Lunch and Learn is made possible by our partner, X4 Pharmaceuticals. Before we begin, I would like to point out a few housekeeping items to keep in mind for today's Lunch and Learn. This afternoon, we are using the Zoom webinar feature. Attendees should be able to see the slides and our presenter and be able to hear myself and our presenter speak. Attendees will not be able to activate their video camera or their microphone. There will be the opportunity for questions after the presentation. You are welcome to submit any questions you have for our presenter as you think of them throughout the session. Please type them in the Q&A box in the control panel on your screen. Please do not include any personal health information, as all questions will be anonymous and read aloud. A brief disclaimer. Please remember the information presented during this event is not intended to be a substitute for medical advice, diagnosis, or treatment. We are here today as a trusted source and friend to provide you with information. Always seek the advice of your physician or other qualified health provider with questions concerning a medical condition. Never disregard professional medical advice or delay seeking it based on information presented during an educational event. To learn about IDF and explore our resources, please visit our website at www.primary-immune.org. The website offers a wide variety of both online and printable resources for anyone seeking information or support for their PI, including our patient and family handbook for primary immunodeficiency diseases. We can also help you find an immunologist or PI specialist in your area with the Clinician Finder. If you're looking for specific resources, IDF has a chronic neutropenia landing page, as well as an entire chapter dedicated to this topic in our patient and family handbook. It's chapter 21. You can find this in the IDF Resource Center linked on screen, along with all of our publications, videos, news, and more. IDF also offers monthly programming and events. We host monthly lunch and learns and bi-monthly webinars covering various topics facing the PI community. And we also have Get Connected groups, peer support, Ask IDF, and our annual PI conference. And now I am so pleased to introduce our presenter for today. Dr. Jim Connelly is an assistant professor of pediatrics with the Vanderbilt University Pediatric Hematology and Oncology Department. He is also the director of the Comprehensive Hematology, Immunology, and Infectious Disease Program at Vanderbilt. Welcome, Dr. Connelly.
All right, thank you, Emma, and IDF and X4 for hosting this Lunch and Learn today. It's always a pleasure for physicians to host these conferences because one, we are, education is a key component of what we do, whether that be education for our trainees or education for families and patients or education amongst each other. And so this is a really important aspect of and a driver of what we do and what we love to do. And obviously neutropenia has been a career interest of mine, trying to understand why patients get neutropenia. And also, obviously, since my primary job as a bone marrow transplant physician is finding safe ways to transplant patients and identify which patients would ultimately benefit from a transplant. So I'm going to go ahead and get started. Okay, just some quick disclosures. That I am an advisory board member for a few pharmaceutical companies which are listed here, which do deal with patients with neutropenia. All right, so we'll start with this slide. I really like this slide. So this is a electron microscope view of a neutrophil. I like it for a couple of reasons. One, it's kind of a good one to look at lunch, just because it does kind of remind me of a few food items. I don't know if any of you like bibimbap, which is a Korean dish, but this kind of looks like it. But really, the other reason is it just tells you how complex the neutrophil is. When a lot of pictures that you see, online or even in histology textbooks, those are images of a neutrophil under a microscope, and the microscope isn't powerful enough to really see these kind of small intricacies of the neutrophil. So when you see those, what are called H&E stains of neutrophils, you can kind of see that nucleus, which is kind of segmented. It is one nucleus. It just kind of is in parts, or excuse me, it's kind of have those segments along it. And you can see a couple of the large granules that are able to be stained, but as you can see here is that the neutrophil is really kind of packed with important things to, do its function, which I don't think I need to, prove to this audience how important neutrophils are. But certainly the complexity of the neutrophil is quite intense. So with that, just kind of a brief overview of what we'll talk about. These are fun talks, but also a little bit challenging because I know some of you are well versed in neutropenia. Sometimes even knowing more about your disorder than your physician may. And there are others who are maybe just learning about neutropenia or could use refreshers on neutropenia. And so I wanted to kind of make sure I did something very broad, starting with some of the basics and then kind of eventually moving on to some of the more intricacies, particularly when it comes to treatment. So we're going to talk about neutrophils. Where do they come from? What do they do? How come they're called sometimes different terms? Are they the same terms? We'll talk about neutropenia, how we classify that. Briefly go through the causes of chronic neutropenia, which are many, and that could be several talks by itself. We'll talk about some complications of chronic neutropenia. Obviously, infection is the biggest one that most of the neutropenia disorders have in common. Development of leukemia is kind of the scary part of having chronic neutropenia, but is really only a risk for some of the congenital disorders, and we'll cover that. Supportive care for chronic neutropenia is really important. We think about the definitive treatments such as G-CSF and bone marrow transplant and newer drugs that are on the horizon. But equally important is understanding what are things that we can do living with chronic neutropenia that can reduce the risk of complications such as infections. So a little bit on the terminology you might have heard or in your reading or on the web or even talking amongst yourselves that, sometimes people term neutrophils differently. And depending on which term you use, it actually may mean something different. So you might have heard the term granulocyte. So these are white blood cells, but they are defined by what they look like under the microscope, meaning they have these large granules, that can be identified with the stains that the pathologists use to identify the cells. And so that includes these are what are called basophil because they pick up this basophilic stain, eosinophilic stain because they pick up this eosinophilic stain, and the neutrophil. And so this is what I was referring to compared to that first slide of the EM, the electron microscope view of the neutrophil, is that the H&E stain under the microscope doesn't kind of fully give you the appreciation of the complexity of the neutrophil. But if you use the word granulocyte, it could be any of those terms. When we talk about neutrophils, it actually encompasses two cells, which are the same cells, just different levels of maturation. I'm going to talk about how neutrophils are made here in a couple more slides, but in reality, when you look at, you can have kind of two forms of maturation of neutrophils. I often kind of explain this to families that when your bone marrow makes neutrophil, it just doesn't make a neutrophil. It makes kind of a baby neutrophil, and then that neutrophil begins to grow up. It becomes a toddler neutrophil, then a preschooler neutrophil, then a elementary school. And once they become an adult, which is truly the polymorphic neutrophil or PMN, it can do all of its functions, or what I call kind of the late adolescent neutrophil called the band neutrophil. It can also do all of the functions of a fully mature neutrophil. So when we count the neutrophil count in the blood, we are actually counting the bands and the polymorphic neutrophils, and that becomes your ANC, or absolute neutrophil count. Now, some of you, may have other kind of earlier types of neutrophils in the blood. I'll go over that in a little bit, but those don't have the full functions of neutrophils. So they're really not called neutrophils yet. They're more called neutrophil precursors that are there. And then the last term, which is commonly used, are phagocytes, and neutrophils are a phagocyte. And phagocytosis, refers to the term of basically engulfing material that's outside the cell, and a lot of cells can do that. And so even though sometimes neutrophils are referred to phagocytes, not all phagocytes are neutrophils. So it's important to know just, these terminology that you may hear or read about or talks amongst yourselves. There is some differences between them. Obviously, we really try to use the word neutrophils because that really kind of describes a fully functioning white blood cell that has all the capabilities of neutrophil function. So I'm not going to go great depth into this, but just as another reference of how neutrophils are made in the bone marrow, and they are one of many different types of white blood cells. But here's kind of the pathway of neutrophil production, and until we get to this N, which is the polymorphic neutrophil. To go from the early cell, early kind of baby neutrophil, which is called the myeloblast, to get to the full neutrophil probably takes 10 to 14 days, depending on how quickly the body needs it, because the body can speed up this process if it's stressed enough to do that. But it does take time to develop that. And where the cells develop in the bone marrow is very dependent on what chemicals are in the bone marrow. And the body can decide, does it want to make more neutrophils or more red cells, or whatever cell type it can certainly kind of shift the production of different cell types depending on the situation that's there. But this is kind of in every neutrophil talk, whether you're a med student or faculty position, just to kind of remind everybody that your bone marrow just doesn't make it straight neutrophil. It actually has to go through this maturation process. And then I bring up here just to let people understand is that, which is really important how we think about chronic neutropenia, is that when we're measuring a neutrophil count, we're actually only measuring a very small number of the total kind of neutrophil pool in the body. So what do I mean by that? So if you could look into the bone marrow, if you remember the previous slide that you had this maturation of neutrophils from very early cells into the adult neutrophils that are here. So adults, late teenagers, early teenagers, these are all the preteen neutrophils. And when you're a preteen neutrophil, we call it the mitotic pool. That means these cells can divide. So it can take one cell and make two cells. Once it becomes a teenager neutrophil, what we call a metamyelocyte, they can no longer divide. So meaning that they will still mature to a fully functional neutrophil, but they lose that ability to proliferate. And so most of our body neutrophils, again, as I mentioned, to be a neutrophil, you have to be in this kind of category here, the bands and the polymorphic nuclear neutrophils. Most of our neutrophils are actually inside our bone marrow. So when we're measuring an ANC in the blood, we're only measuring probably 2 to 5% of the neutrophils in our body, which is a small amount. And the reason why we have so many neutrophils in our bone marrow is because on a daily basis, it's important for neutrophils to be going through our body because they can look and sense and try to see if there's infection or tissue repair they need to do. So there's a surveillance mechanism of neutrophils. But we also need to know that if we get an infection or get an injury to the body, that our bone marrow can basically push out lots of neutrophils to allow them to take care of that threat. And so remember, because it takes, that 10 to 14 days to make a full neutrophil, you want to have kind of that army sitting at the base for it to develop. And this is important when we think about chronic neutropenia, because some patients with chronic neutropenia have very little neutrophils in the blood, but they have a lot of neutrophils in the bone marrow. And so the reason why some patients with chronic neutropenia are at low risk for an infection is because even if the blood neutrophil count is low, let's say they get an infection, they can basically have all these neutrophils kind of sitting at the base that can go out and fight the infection. However, there are some patients who may have the same neutrophil count in the blood, but may have very little neutrophils in the bone marrow, such as some of the congenital neutropenias. If those patients get an infection, they don't have this army to go out and fight the infection. And so they are more likely to actually get the infection and then become sick from it. And so this is a very important concept for physicians caring for neutropenia patients to understand and hopefully predict, which of their neutropenia patients are at risk, high risk for infection or low risk for an infection. And how you figure out if you have neutrophils in the bone marrow, there's a lot of ways to do that. Of course, one is to get a bone marrow biopsy, which isn't necessary for all patients with chronic neutropenia. That's certainly another discussion. But it could be that you come in with an infection, you come in with maybe a pneumonia or a sinus infection or an ear infection if you're a child, and you notice that your neutrophil count before the infection was very low, but when you came in with that sinus infection, it rose to a couple thousand. That would tell you that the bone marrow is able to respond appropriately to the infection. I like the slide. I use the slide quite a bit because, again, I think it's fun to think of neutrophils, being a protector for our body and just how really cool they are. So this was a quote that's listed here, and it just reminded me of Rambo. So mature neutrophils emerge from the bone marrow intent on pursuing one simple yet essential question: has host integrity been compromised by potentially harmful invaders? At its disposal is an impressive arsenal of antimicrobial weapons that are deadly, indiscriminate, and brutish in their application. These weapons can prove to be just as dangerous to the host cells as their intended target, the microbial invaders. Therefore, the deployment must be executed with exquisite precision and timing. So that, as a physician who is interested in the immune system, certainly is very exciting. So this really is a very simple kind of cartoon of what the neutrophil can do. But as that previously slide mentioned, is that the neutrophils are so powerful, even though we're kind of focusing on neutropenia, it's important that their function is a little bit restrained. Even though like our focus is on how neutrophils are either absent or not working as well, in fact, if some neutrophil function is not well constrained, it can cause disease, and it's been associated with other disorders such as lupus. But the basic functions they do are kind of divided into these kind of 4 categories. So the first is degranulation. So if you remember that first EM slide that I showed, they had all these kind of granules inside them. They can be released into the environment outside the cell and cause direct toxicity to infectious organisms. Phagocytosis, we mentioned that earlier, so that's when they can actually engulf extracellular microbes like bacteria and then digest them inside the cell. They make reactive oxygen species. They can make it outside the cell and inside the cell. So basically, these are kind of toxic chemicals, which are very kind of noxious and can kill invading organisms. And then a cool thing is neutrophil extracellular traps or nets. And as seen here in the bottom part of the cartoon, we're still learning why and the function of these nets. But essentially what they do is they basically take all these nuclear proteins and kind of extrude it out of the cell. So kind of basically the cell kind of opens up and kind of spits out its innards. That's probably the best way to describe it. And then it's this kind of tangled sticky net, which kind of traps these microbes. And it's felt that sometimes neutrophils do that as kind of they're going to die anyway, or as a last ditch effort to kind of kill the infection, is that they're just going to kind of spread out this sticky net and at the same time cause the cell to die. In addition, it's important to know the neutrophil is part of the immune system. So it also has a lot of communication with other immune cells. And so it's part of a network of the immune system. And so even though we're focusing a lot on neutrophil function, it's also important, for communication with other immune cells. All right, so we'll transition now to neutropenia, which is why you're all here. Hopefully you all understand how cool and important the neutrophil is. So now let's talk about what we call neutropenia. First of all, the neutrophil count varies with age. And so here on the right is just kind of a graph of normal neutrophil counts at the time of birth for full-term infants over time. And because of the stress of delivery, over the first few hours, the neutrophil count rises and then kind of actually goes low for the first year or two of life in the infant. And so what we call neutropenia for the first week of life is actually if they're less than 3,000. Once they get a little bit older, the neutrophil count somewhat drops. And so for the first 2 years, after that first week of life, we consider patients neutropenic if they're less than 1,100. And then here's what probably most of you are familiar with, kind of this classic kind of categorization of neutropenia, mild being 1,000 to 1,500, moderate 500 to 1,000, and ANC less than 500 being severe. Now, these correlate very well with your infection risk, only if you don't have that kind of reserve of neutrophils inside the bone marrow. So if your ANC in the blood is less than 500 and you don't have a reserve of neutrophils in the bone marrow, your risk for infection is incredibly high. If you're 500 to 1,000 with the same bone marrow setting, you're at moderate risk for infection. But really, if you're above 1,000, in most instances, your risk of infection is only mild compared to patients with normal neutrophil count. So that's why that kind of categorization is important. But as we've been talking about, it's also important to know how it applies to what's going on in the bone marrow. What is also important to know is that the kind of quote unquote normal neutrophil count is very race and ethnic dependent. And so a lot of these kind of normal ranges that have been put out there for whether it's neutrophil count or a lot of the laboratory values have been described in kind of a European Caucasian population. And so they collect samples from many normal patients, and then they come up with these kind of quote unquote normal ranges. But unfortunately, they are very biased toward the European Caucasian population. And so this is trying to be remedied in medicine as best as we can. But we do know that African Americans, for example, as well as other ethnicities from kind of Mediterranean areas, they can run lower neutrophil counts, and they should not be considered neutropenic. They should be considered that that's the normal neutrophil count for their race or ethnicity. And so the hematology community is becoming, much more aware of this discrepancy. And some, African Americans can run, neutrophil counts in the severe and moderate categories, and yet it doesn't put them at risk of any type of infection. It's just that is kind of based on their ethnicity of where they run. So this is going to be a continued, kind of endeavor for us as hematologists to better categorize what is the true kind of quote unquote normal neutrophil count that is dependent on a lot of factors, not just age, but certainly race and ethnicity. So another way to think about it, which is how I like to think about it. So hematologists love gardens. I like to garden. But the bone marrow is I think a good analogy for making neutrophils. So it's a garden. You need all the right things in the garden to make a neutrophil. But because I try to think of what do patients with chronic neutropenia, when I think about those patients, well, I want to know why they're neutropenic. And then two, I want to know, well, what's the problem with their neutropenia? Are they at risk for infection? Are they at risk for leukemia? Are they at risk for other manifestations of their disease that may or may not even be related to the neutrophil? But you can break it down, chronic neutropenia causes into three broad categories. So you could have decreased production. So this is hopefully not your garden, but it's basically, there's something wrong with the bone marrow. So you could have bad seeds. So this could be that you have a congenital disorder that results in either poor production of neutrophils or maybe just bone marrow cells in general. It could be poisons. These could be medicines that are being taken. It could be toxins from the environment. It could be that you're not getting the proper nutrition. You could have something in the bone marrow like weeds in your garden. So these would be patients who may have scarring or fibrosis in their bone marrow, leukemia, myelodysplastic syndrome, those kind of infiltrative diseases. And then it could be infections. So infections typically don't cause chronic neutropenia, but it can cause neutropenia certainly over the course of days and sometimes weeks in some patients. The second category is that their bone marrow is fine. It's just that they're using up their neutrophils, and sometimes it can be very natural. So if you get a severe infection and you need neutrophils, your marrow will just dump out neutrophils into the blood to fight the infection. And so it's not uncommon, particularly in really young patients, that after they have a severe infection, they'll be neutropenic for a couple of weeks and waiting for that bone marrow to kind of catch up with that. And then there's destruction. This is, kind of some of the more common causes of chronic neutropenia in young children and adults, where the immune system, for one reason or another, which we don't quite understand yet, decides to shorten the lifespan of the neutrophil, meaning the immune system destroys the neutrophils before they kind of live out their normal life. And the last one is ineffective trafficking. So remember, that small percentage of neutrophils are in the blood, but there are conditions, some of them are normal and some of them are not normal, where the neutrophils don't know where to go. So they may have trouble leaving the bone marrow because they're getting the improper chemical signals. A lot of our neutrophils can go to places like the spleen, the liver, and the lungs. And if you have a large spleen, for example, sometimes those neutrophils will kind of take a long time to get through the spleen. So the spleen kind of slows down the passage, which can make the neutrophil count low. But really the high infectious risk is really in the decreased production kind of category. Potentially, if neutrophils are having trouble going where they need to, that could also raise infection, and very variable whether if your body is destroying them more quickly, if that puts you at high risk or not. That's a little bit more variable situation. So I'll start with the congenital neutropenia. So these are kind of the bear garden type category. And many genetic causes. I probably need to update this slide that I put together a couple of years ago, because our knowledge of genetic causes that cause this are certainly expanding. A lot of that is due to kind of, broader recognition that neutropenia may be caused by genetic causes and the access to genetic sequencing in these patients. And as you can see here, not only are there lots of genes that can give you chronic neutropenia, but how they impact the cellular function is quite different, in lots of different categories that can relate to neutropenia. The more common causes, or at least the more well-described one, is of course severe congenital neutropenia, and this is defined as the name would mention, as you're born with it. It causes severe neutropenia. So often these patients, ANC is close to 0. Very high risk for bacterial infection as well as fungal infection. We often focus a lot on the bacterial infections, but neutrophils are also very important for fungal infections. Typically what we see here is when we get bone marrows on patients with a lot of the congenital neutropenia disorders, they often see that there's what we call maturation arrest. So what does that mean? So here on the top cartoon here, this is the normal maturation. So it goes from the baby neutrophil all the way to the parent neutrophil. But what can happen if you have disorders in neutrophil production is that maybe they can grow up to be, a toddler neutrophil, but the defect prevents them from becoming fully mature. So what happens is you kind of get a block of maturation and you get kind of a buildup of these precursors. And here's a very small snapshot of a bone marrow. And as you can see here, these are not fully grown neutrophils. They tend to have a lot of what we call promyelocytes, which are kind of the elementary school neutrophil. And so why is that? So most of these, the majority of congenital neutropenia, around 50% or so, are related to this protein called elaine. So elaine it makes a protein called neutrophil elastase, which is one of many enzymes that the neutrophil uses. But what happens when you have the defect is that what this picture is here is that this is kind of what the protein actually looks like. Now, it's not a string, so I didn't mean to kind of do that. But when we draw proteins, sometimes it's easy for us to kind of draw it as a single line and just to see where all the loops are, where it kind of twirls around, where it kind of goes back and forth. In reality, proteins are these big globular structures. But what's important to know about proteins is that in order for them to function, they have to fold correctly. So meaning that they have to be in a certain conformation. So whatever function they're doing, they have to be in the right kind of what we call three-dimensional structure. And when you have mutations in the ELANE protein, it can really interfere with how that protein folds. And so when the baby neutrophils start to make neutrophil elastase, what happens is that the cell tries to fold that protein in the right way, but when it does it folds it incorrectly. And that puts a ton of stress on the cell, and the cell says, that's too much stress, and our cells are meant to die if there's too much stress. And so what happens in that situation is they go through something called the unfolded protein response, or UPR, and that causes the cell to die. So that's why the cells stop at promyelocyte phase, because that's when the cell has tried to make enough of this elastase protein that it causes too much stress and causes it to die. There's kind of two clinical presentations of ELANE neutropenia. One of them is, first of all, this is autosomal dominant. So what that genetic term means is that if you have a single mutation, that's enough to cause disease. If you're autosomal recessive, you have to have a mutation in each gene. But in this case, you only need one, because if you have one mutation, that's when it causes the stress on the protein. And so you can get the most common form is severe congenital neutropenia. So that's when the ANC is very low all the time, unless you're getting, GCSF therapy for that. But there's also cyclic neutropenia, which can be caused by the ELANE protein mutation as well. And this is a little bit different. So for reasons that we're still trying to understand, instead of the neutrophil count being low all the time, it goes up and down. And it goes, this kind of period of fluctuation is usually 3 to 4 weeks. But about a week of that time, the neutrophil count is incredibly low, so close to zero. And that's when they're at really high risk for infection. And so those patients, we used to kind of identify that by getting CBCs 2 to 3 times a week. And occasionally we will still do that. But since most of these are caused by mutations in ELANE, about 90% of them, and it's so easy to get sequencing now and relatively cost effective, we just go forward with the gene testing that's there. A couple other disorders. So these moving a little bit into what we call syndromic neutropenia, which means that it's, those other defects, the ELANE defects are just going to affect the neutrophil count. But the syndromic means that the mutations or mutation can cause, cause problems in many things, not just the bone marrow or the neutrophil production. So one of them is Shwachman-Diamond syndrome. So this is an autosomal recessive disorder. So you need a mutation in both the mom chromosome and the dad chromosome to come together in the child to have the disease. The gene is called SBDS, and neutropenia is almost in all patients, not all, so 80%, but other patients can have low platelets or low hemoglobin. It's kind of classically described as also having loose stools and trouble gaining weight, because your pancreas does a lot of things, and one of it does is it makes digestive enzymes, what we call the exocrine pancreatic function, and that can be impaired in patients with Shwachman-Diamond, and a whole host of other potentially congenital defects, particularly musculoskeletal, that are associated with that. And these next couple disorders are also syndromic neutropenia disorders, and why they're interesting is because GATA2, for example, was really discovered about 10 years ago, and so this is one of the newer disorders, but as it turns out, is relatively common. And what I mean by relatively in the rare disease world is not that, everybody's neighbor has one. It just means that for kind of the rare neutrophil congenital disorders, this is becoming one of the more common ones. And so GATA2, this is also autosomal dominant, so you just need one mutation. But you can see GATA2 is really important to making blood cells, including neutrophils. And so if you lack GATA2, you tend to have low neutrophils, you tend to have low monocytes, and many other cell types as well. And so these patients have not only neutropenia, but other components of immune deficiency. And here's a whole host of kind of both hematopoietic and immune defects, but really you can see that it affects other components of the disorder. Lymphedema is pretty common as kind of one of these things, and as well as developing kind of pulmonary problems. Some of those are related to infection, but some of them are related to some of the dysfunction of the immune cells. And then finally, WHIM syndrome from a syndromic neutropenia that also has a large kind of impact on other parts of the immune system. This one is a little bit different because unlike the other ones where it's kind of more production of neutrophils, this is where the neutrophils get trapped in the bone marrow. And so this is an old term, but WHIM stands for warts, hypogammaglobulinemia, so that your gamma globulins are a protein that your immune system makes to help fight infection. The I is for bacterial infections and myelokathexis. So what does that fancy term mean? So it's mutations in CXCR4, which is basically the CXCR4 protein is on your neutrophils and helps direct where it's supposed to go. And so if you have overactivation of CXCR4, it basically tells the neutrophils to stay inside the bone marrow. And when that happens, the neutrophils kind of get stuck there and they get old and they don't look very well, and they begin to die instead of actually going into the body and doing what they should. So they get these very bizarre looking neutrophils here, which is what's kind of historically was called myelokathexis. But the thing about this is these patients have very low numbers of neutrophils. But as it turns out, there's ways to get the neutrophils into the body. And sometimes infection by itself can do that. So even though their neutrophil count is very low, their infection risk is not the same as patients with severe congenital neutropenia, but still at risk for infection. And they get lots of other problems as well, warts and other bacterial infections, partially because of the other immune defects, and can some older patients are actually quite sick from this disorder. All right, so now we're going to quickly move into drug-induced neutropenia, which is, these are kind of the acquired disorders. So these are more of, things that are happening outside of the neutrophil system that are impacting either its production or in most cases their lifespan, so causing them to be destroyed more common. So even though, chronic neutropenia, we don't always kind of associate with drugs, but some of these drugs you have to be on. So we have patients who have epilepsy, and a lot of the epilepsy drugs can cause neutropenia. And if they have control of their seizures on the medicine, it can be hard for us to change to a different medicine. So, but we also see it in the acute setting, of course, because the onset can be fairly quick. So typically 1 week or even months after starting the agent, you can develop this. These patients can be sick. They can present with severe infection, particularly if the drug really suppresses the bone marrow. The etiology is either direct toxicity, meaning that the medicine actually impairs production of neutrophils, or the other thing, what happens is that sometimes the drug will attach to the neutrophil, and when the drug attaches to the neutrophil, that becomes essentially a new target to the immune system, what we call a hapten. And so the immune system, for some reason, thinks when the drug's attached to the cell is that's strange and I should get rid of it. And so when the drug attaches to the neutrophil, it decides to destroy that. Treatment is usually withdrawing the agent if you can. Sometimes you can't do that. G-CSF can also be used. I'm not going to go through this in detail, but there's a lot of drugs that do that. Some of them common, some of them not. Certainly a lot of your doctors, if you're put on these medicines, they'll check a count beforehand just because they know it's highly associated with that. It is important to know if you have chronic neutropenia and you're on certain medications that, you let your physicians know, like, hey, I have chronic neutropenia. Is there any chance this drug could lower my neutrophil count? That's always good questions to ask. This is readily available information for your physicians. Sometimes, I as physicians, sometimes even though we may know you very well, like sometimes that can jog our thoughts like, oh, yes, that's right. That's a great question. Let me see if this causes neutropenia. And if it does, let's talk about alternative agents. So it's always a good question when you're starting medicines. How is this going to impact your neutrophil count? Again, most drugs are going to be completely safe for the neutrophil count. I don't want to make you think this is a common issue, and most drugs are very safe to use in chronic neutropenia, but it's always good to know, the impact of the drug. Immune-mediated neutropenia, again, for some reason that we don't quite understand, your immune system tries to get rid of your neutrophils quicker than it should. And so we kind of see this in very young children and then older children and adults. In young children, it almost always goes away. And it happens at about a year of life. And this is called a lot of different names, which we need as hematologists, we need to kind of come to some consensus of what we're calling these. But essentially, I think I prefer autoimmune neutropenia of infancy. And usually these patients are not sick. It's often picked up because they're getting a count check to make sure they're not anemic. And they get referred to us because their neutrophil count can be very low, like a couple hundred. But they're usually not symptomatic. And the reason is because their bone marrow is packed with good neutrophils, and it can make neutrophils in the setting of infection. It usually goes away in a couple of years, and doesn't require kind of long-term follow-up. A little bit different in older children and adults. And if you see it in older children, it can always be part of a broader immune dysregulation syndrome, some of which are listed there. Evans syndrome just means you have autoimmune disorders of more than one cell type. So it could be neutrophils and platelets, neutrophils and red cells and platelets, or sometimes all three. Lupus, ALPS, which is autoimmune lymphoproliferative syndrome, and a very common immune deficiency called common variable immune deficiency, or CVID. If it's associated, if that's the only autoimmune problem you have, we call it primary autoimmune neutropenia. However, if it's associated with some other coexisting immune disorder, a common one is lupus, we call it secondary autoimmune neutropenia. Again, the terminology can be confusing. It actually does have some importance, because if it's usually secondary, meaning that there is some other process that is also present like lupus, often the treatment for lupus will help the neutropenia. And so we don't necessarily have to directly treat the neutropenia in those situations. And then there's this kind of wastebasket term. Idiopathic, for those of you who don't know, just means that we're not sure. It's just that physicians don't like to say that we're not sure, so we come up with a fancy medical term, which is idiopathic. We do think this is also immunologically based. It's just harder to prove, but can also be found incidentally coming in for counts, blood work for some other reason. And when we see it, obviously these patients need to be worked up for other causes of neutropenia, and make sure we rule those out. But again, it's idiopathic, which means we don't know the cause, but it's probably because your immune system makes these chemicals called cytokines, which are really hard to measure, which drive the neutropenia. These cases are also usually benign, but occasionally some of them will have things like infections and mouth sores and require GCSF. Okay, so move on to complications. I think I have about 10 minutes left, and then we'll have some time for questions. So infections is obviously the big issue with chronic neutropenia. For the congenital disorders where they have a marrow that doesn't have this bank of neutrophils, we know they're high risk if they're less than 500, but if you can get them above 1,000 with whatever management you have, often GCSF, you can really lower their infection risk to very minimal. As I mentioned, the primary autoimmune and chronic idiopathic are in general low risk. Again, this is not a uniform statement for every single patient. There are certainly a subset of these patients which are at moderate risk of infection, sometimes higher than that. If you have secondary autoimmune neutropenia, they seem to have other problems and higher risk of infection. And that might be because their neutropenia is not responsive to when infection comes in. Often it's because other parts of the immune system are also impacted, or they're on medicines. So if you have lupus, you may have medicines that also suppress your immune system. So it's a much more complex disorder, which is leading to higher infection risk. When you looked at infections, I'm not going to go through all this in detail, but I looked at this about a year ago, and we're actually studying this here at Vanderbilt. is understanding what is truly the infectious risk in chronic neutropenia. Surprisingly, it hasn't been well studied, surprisingly and unfortunate, and hopefully we'll start to look more into this to understand what the true infection risk is. But here are some of the larger studies that are there, and I'm not going to go through the details, but some of them were pediatric and some of them were adult. And in general, the pediatric patients that had autoimmune or idiopathic neutropenia, they had very low rates of severe bacterial infections. When looking at, for example, in the Italian registry, when they looked over roughly 10 years, they only found 3 bloodstream infections, which you could argue is probably on par with the general population, because even patients without neutropenia can get blood infections. When you go into the adult kind of literature, it's a little bit more than you do in the pediatric population. But as I mentioned before, if you have a secondary cause of autoimmune neutropenia, the rates of bacterial infections were much higher in those, again, for likely the causes that I just discussed. And so even though we have these kind of nice categories and to call diseases, is that understanding the infection risk is not always straightforward. A little bit on COVID-19 and congenital neutropenia. Obviously, this has shook up the medical community, just as as in all of us in various ways. And the SENIR is definitely trying to get a better understanding of this. It's a little hard because often when these kind of new infectious outbreaks happen, a lot of it's going to be patient-reported outcomes, which is great, but sometimes it's only if they contact you. So the registry has been hearing about some patients who have had COVID, and many of them have symptoms similar to, if you had normal neutrophil counts, but there have been a small number of deaths. And again, whether that was related to the neutrophil count, we don't know. We don't have all those details. Some of the members of the board I'm sure are kind of looking into that a little bit more. But I think the thing here is that when you have a new disease and small numbers of data, it's going to be hard to understand the full impact. One thing that the David Dale and Peter Newberger had come out and said is just make sure you get vaccinated, continue all the protective measures until we learn more about this. And they also said, don't stop your GCSF if you get SARS-CoV-2. So really a lot of the things that all of us should be doing, until we learn more about this. And we've certainly learned a lot since its beginning, but, unfortunately, we're living with this and we'll continue to learn more about it. We often get questioned about vaccinations. One thing to know is neutrophils are not critical for vaccine response. And so most patients with chronic neutropenia should have normal vaccine responses. Because they can reduce the risk of infection, you should definitely get your vaccinations. It is noted that some chronic neutropenia can be associated with a combined immune disorder. Most vaccines are dead, means you cannot get the infection from it. That includes influenza, that includes the COVID vaccine. Those are dead vaccines. So you can't get the infection from them, but some of them are live. It's like chickenpox and MMR. If your neutropenia is part of a broader immune system disorder, those vaccines may not be good for you, because if your immune system is very weak, not from the neutrophil perspective, but other parts of the immune system, then you could get an infection from those. So always ask for the live vaccines, whether that's safe for you, but probably for the majority forms of chronic neutropenia, it will be. Oral care is super important, which I think most of you know. Certainly neutrophils are really, I always tell my trainees, neutrophils are very important for all the surfaces that are contacted with bacteria, lungs, skin, mouth. So if you don't have neutrophils, those are prime areas you get infection. And if you don't have great neutrophil immunity, you can get gingivitis, which is inflammation of the gums, mouth sores. So regular dental visits, kind of the standard kind of oral hygiene care. There are some kind of supportive care to help for patients with mouth sores. Some of them are successful or not. I'm not going to go into great detail in those, but there are things that can be done to try to reduce the amount of mouth sores that are there. But again, not great studies that have looked at that. A lot of this we've kind of learned from other colleagues and sometimes from patients what they have done to kind of help with the mouth sores. Another complication is leukemia, and this is really in the congenital form of neutropenia and only a subset of those congenital neutropenias. Most of the research that has been done on leukemia has been done in two disorders, the Elaine neutropenias and Shwachman-Diamond syndrome. So this is the SCN Elaine, mostly Elaine patients. This is a growth curve of what percentage of patients are developing leukemia over time on GCSF. After 10 years, about 21% of patients will develop what's called myelodysplastic syndrome, which just means that the bone marrow can't make cells very well and can often turn into leukemia or frank leukemia. And the type of leukemia that they get is acute myeloid leukemia, or AML. Unfortunately, even though our success with reducing infections with kind of everything that we've been talking about in GCSF, which I'll get into, mortality from leukemia is still the number one cause. And so patients who are at risk for leukemia, as some of you may know, may be getting regular CBCs, maybe getting regular bone marrows as much as once a year to kind of find early signs of MDS or leukemia. So hopefully you can treat it quickly when it's kind of at a low stage of the cancer. Primary treatment is GCSF. We're going to go about treatment very quickly. GCSF and transplant will be the main focus. Most patients with congenital neutropenia will respond very nicely to GCSF. It has dramatically reduced the risk of severe bacterial infections, but we still see that. On the previous graph, it was 8%, and those are either patients that are not taking it regularly, have bad outcomes from it, so they're not taking it as prescribed, so like bone pain or other conditions. Patients who have congenital neutropenia are at risk for AML and MDS. Of course, we can think about bone marrow transplant for a cure. So how does GCSF works? So one thing to know, we make GCSF, and how much our body makes depends on the situation. So if we get an infection, our body makes more GCSF and to make more neutrophils. And so, but what it does is, so it's made by many cells inside the body. It causes more proliferation. If you remember those early cells in the bone marrow, they can still divide. And so it causes those to divide a little bit more. And then it speeds up. So, that 10 to 14 days to make a neutrophil can be shortened, maybe by a couple days by giving this. It is the principal cytokine for also releasing neutrophils. So as I mentioned, most of our neutrophils are inside the bone marrow. And when our body gets infected, we make a lot of GCSF and pushes those into the body. So that's a huge component, not just to make neutrophils, but to actually release them from the bone marrow. And it also activates neutrophils. So GCSF use, it's for the congenital neutropenias who have neutropenia. It is 100% recommended. We don't have to get them to a normal neutrophil count, but if you can just get them to 1,000 to 1,500, you put them out of kind of major infectious risk. Cyclic neutropenia would be another congenital cause, usually requiring low dosing. It's important to know that there's still a lot of research understanding the impact of GCSF on leukemia development, and that's still a very active area of research. Certainly congenital neutropenias, the risk of not being on GCSF is gigantic. And so even though there might be an association with leukemia, which we're still trying to understand, the risk of infection is so high without it. That's why we still recommend to give it. But in the primary and chronic idiopathic neutropenias, it has never been associated. There's been no study that has shown that it's associated with cancer. We don't use it very commonly because usually most patients don't need it, but occasionally we do. So if they're having lots of infections, mouth sores, what we call stomatitis, or impacting their quality of life, they're constantly going to the ED or because of fever and things like that. Usually these patients require really small doses, or even every other day or 3 times a week dosing to give them to a protective neutrophil count. It's important to know that these biosimilars, so when I started my career, there was just Neupogen, but once that patent ran through, a lot of other companies started making these other products. It's important to know that they all work the same. So it's not like you're getting an inferior or superior product, and often these are being dictated by your insurance plan. So not really any differences in efficacy or adverse effects. The one thing to know about it, though, is that the dosing can be different. So some of them come in pre-filled syringes, some of them come in a vial that you can draw up, and sometimes the concentration is different. So certainly if you're switching from one product to the next, you want to make sure that the dosing, so you might be giving more or less depending on the concentration. So you just want to make sure that you're still getting the same kind of standard dosing. And then finally, transplant. We don't do this very often for neutropenia, but there are some that need it. So the indications, the absolute indications for transplant for congenital neutropenia is if they develop leukemia or MDS, if they develop some genetic changes that we can pick up on a bone marrow biopsy, that would are concerned that they will turn into leukemia at some point in the near future. And in some cases of Shwachman-Diamond syndrome, they can develop bone marrow failure. Possible indications, which are kind of the gray area, which require a lot of discussion, is if you're requiring high doses of GCSF, if you have a mutation that is associated with bad outcomes, or you can't tolerate GCSF, you have too much bone pain, for example. An area that we're still learning about is that some common genetic changes we see. So when your bone marrow doesn't work very well, it's more likely to develop other mutations. And we can follow these and detect those with kind of our genetic testing today. But if you develop those, we're still learning what to do with them. Like, can we just watch them? Should we go to transplant? At least for now, we feel with the evidence that we have, just kind of careful watching is still kind of the recommendation. But hopefully we'll learn more about those as we collect more data. The outcomes for transplant are decent. There's a reason we don't do it for everyone, because some patients die from transplant. Really determines how well the outcome is also very largely based on the donor type. So here, if we're looking at transplant for SCN, and you look at patients who have a matched related donor, a matched unrelated donor, or a mismatch, as you can see here, the patients who had the mismatch, so less ideal donor, had poor outcomes. So when you have the discussion with your physician, should I get a transplant, knowing what other factors may mitigate the risk, such as having a good donor, is certainly important for those. If you look at outcomes, they are better if you don't have leukemia. We do transplant for patients without leukemia. Again, those could be patients who are not responding to GCSF. But the importance of trying to identify patients at high risk for AML and MDS, just because the transplant outcomes are better if you can get them there before that happens. This is more kind of illustrated better in the Shwachman-Diamond populations. So these are two studies done by the CIBMTR and a European cohort of Shwachman patients. The CIBMTR is a transplant registry that all US centers report to, as well as some other international registries. But if you have AML or MDS with Shwachman-Diamond, the transplant outcomes are incredibly poor, particularly if you have AML, as opposed to having SDS, Shwachman-Diamond without AML, which is basically replicated here in a different cohort where outcomes with patients with AML and MDS are incredibly poor. People are also asking about what are the new therapies. There are several that are out there. The important thing to know is that this process takes forever, okay? Which is good, because we want to make sure that the drugs that we are giving you are safe. But I could imagine, and as a physician as well, when you want to help your patients and you know the drugs are out there and you feel they're going to work and you feel they're going to be safe, I just can't pull it off the shelf. It has to go through this process. And the US is very strict on this. Because they want to make sure that the drug is safe for patients and that it works. And so it's a good safeguard, but it does really kind of, for rare disorders where you're trying, where it's hard to find patients to enroll on trials, it can be really difficult to get these through quickly. But there's a lot of drugs that are kind of in the preclinical phase, which means that they're doing it on cells or mice or monkeys or whatever research they're doing to get that information for safety and efficacy. And then once they have that, then they can propose a clinical trial. Things that are being looked at is an actually elastase inhibitor for SCN, gene editing and gene editing and gene therapy for Elaine-associated neutropenia. And then in the Shwachman-Diamond world, really looking at ways to kind of improve the protein production and function of the SPDS protein. So quick summary, many causes of neutropenia, and we talked about the complications. Treatment involves certainly supportive care and GCSF, and transplant is curative, but really reserved for patients at high risk. And I'm sorry, I ran a little bit longer than I thought, but I can say extra for questions.
Awesome. Well, thank you so much, Dr. Connelly. That was an amazing presentation. It was so thorough. And to our audience, I know we are over, or we're just close to the top of the hour, but Dr. Connelly is kindly sticking around for a bit to answer some of our questions. And I see we have a bunch to get through, so we will do as many as time allows for. So thank you, everyone, for understanding. All right, again, my name is Emma Mertens. I'm the Program Manager of Community Health at IDF, and leading us through the Q&A today, we have Dr. Jim Connelly. All right, Dr. Connelly, this first individual asks, neutropenia has developed during treatment for lymphoma and has continued for 11 to 12 years after. Can this represent a worsening immune system or autoimmune neutropenia or damage to my immune system?
Yeah, so we have seen, again, I'm a pediatric physician, so I have as much experience with adults. First of all, some of the medicines that are used for lymphoma treatment can have some chronic neutropenia. So rituximab is a common medicine used for lymphoma, and we can see patients who develop neutropenia for months. It usually resolves over time. Kind of the development of cytopenias post lymphoma therapy is very complex, and for kind of the questions that you had posed there, I think there's certainly, I think when we see that, one, could it be that there was some sustaining kind of damage that had been done to the bone marrow, which is preventing from making cells? Or could there have been some changes in the bone marrow itself that cause it to, not directly, when I say damage, and what I mean by that is that could there be some kind of small genetic change, which makes it a little bit harder for the bone marrow to function. And then, as you mentioned, could there be an immune related component? And so meaning that, the immune system, when we give chemotherapy, we think that, yeah, you're suppressing the immune system, but when you do that, and the immune system comes back, it can work differently, and can work in ways that we don't like it. And could it be the immune system which has changed undergoing therapy that is causing the neutropenia? So that's a really tough question to answer. I think I agree with you for those reasons that are there. There are probably multiple potential causes, or sometimes multifactorial. And unfortunately, sometimes we just don't know, because even though those are all possible, potential ways, but it can be difficult for us to come up with a diagnosis.
Thank you. All right, next question. This individual says, my daughter carries the Elaine gene as well as the Cohen syndrome gene for neutropenia, and she has a severe case. Have you seen other cases where some have both the Elaine gene and the Cohen syndrome gene?
So I'll make a couple comments on that. So no, but I think the reason why I would cause pause. So genetic screening is great these days, no question. And so we are thankfully being able to identify patients quickly and relatively cheaply. So in the past, we'd have to go through all these bone marrows and all this other kind of testing. The problem with gene testing now is that, since we're screening so many patients, that sometimes we find a mutation and it's not really a mutation. And so, we always kind of double check ourselves when we find that there might be more than one cause. It can certainly happen, but that's incredibly rare. And so, you have to be careful when you see that you have a genetic change. The majority of genetic changes are not mutations. So, for example, when we screen for neutropenia disorders, we'll send about 450 genes. And not all of them cause neutropenia, but a lot of them are involved with the immune system. And on average, we'll get about 10 changes in genes that come back to us, and almost always they're not causative. And so I think part of it is understanding where those mutations are, and if they truly impact the function.
Thank you. This next individual asks, are you familiar with any connections between chronic neutropenia and anxiety and or depression or other mood disorders?
Yeah, it's an interesting question. Anecdotally, yes. And again, kind of fatigue, mental kind of health are very complex disorders. And whether it's related to having to live with a chronic disorder, or is it because some of these are immune based, for example, and when you have kind of chronic immune activation for whatever purpose, we feel that those can be contributing to mental health issues, just because low levels of inflammation have kind of been noticed in patients with mental health issues. And so my answer is yes. Why we see that association, I think is an interesting area of research. And, because I've seen patients who have it and the neutrophil count gets better, but they still have the mental health issues. So perhaps the primary process is still hanging around, even though the neutrophil count goes up. But again, there's so much things we need to look into in chronic neutropenia. And so when you guys have these questions, I would continue to bring them up, and because I think we as physicians need to look into it more.
Thank you. This next individual asks, my neutrophils always go down with IVIG. Why is this?
Yeah, so could be a few things. So one, so when you get so how IVIG is made is that basically whenever you donate blood, they take the blood, they spin it down, and they separate it into different components. And they take the plasma, which is the liquid part that contains all the protein, and then out of that, they take a small part of that to make IVIG. So that means when you're getting IVIG, you're actually getting IVIG from hundreds of donors. So it's super expensive because of that. And that means that some of those donors could make antibodies against your neutrophils. And so we've had patients develop red cell hemolysis, which means the red cells break down after IVIG. So it could be because those antibodies are attaching to the neutrophils, but then once they get cleared, your neutrophil count goes back up. The other thing that IVIG does is it does modulate the immune system in ways that we don't completely understand. So could it kind of turn on the immune system or suppress the immune system in ways that cause the neutrophil count to go down is also a possibility. But yeah, it's an interesting thing. I've seen it as well, but again, it's one of those areas that we just don't quite understand.
Thank you. Next question. Are you aware of the connection of neutropenia and an inability to develop a fever with infection?
So that's complicated. I mean, there's usually so I'll say this. I think if you don't have neutrophils, you can still make a fever, because there's a lot of, so what fevers are just your body making chemicals to induce a fever. And so neutrophils are part of that process, but usually you have other parts of the immune system that do that. That being said, if you don't have neutrophils, the infection may not always look like you would commonly see with that. And so, for example, there's a disorder called chronic granulomatous disease, or CGD, where their neutrophils don't work. And they can have a severe infection and you have no idea. And so often those patients are screened with blood work to look for infection, or sometimes some of them undergo imaging. So the answer is maybe. I would say most situations of kind of neutropenia, you'll still have a fever if you're sick. But certainly there could be situations where it doesn't. And the other thing too is that, you need a lot pus, and pus is neutrophils, right? So what I say, the infection may look different. For example, a kid may have an ear infection, but it may not be filled with pus because that's dead neutrophils. And so infection can look different as well. But usually the general signals such as fever are still going to be there, and certainly can be impacted if you're on steroids or other things, because those definitely can suppress your ability to have fevers.
Thank you. Are you okay for a couple more minutes, couple more questions? All right, next question. This individual asks, what is the proper lab workup for autoimmune neutropenia?
That's a hot topic. So by definition, so autoimmune, so how we define autoimmune is that you have an antibody that you can identify against neutrophils. So the problem with getting that testing is that you can get this test, and I'll send it as well as my colleagues, not on everyone, but it's not a very good test, and it's nothing to do with the company. It's just neutrophils die outside the body very quickly. So we do research on neutrophils, but we have to collect them, quickly get them to the lab, and on the same day to do their tests. All the other tests, we can take it, freeze it down, put it in the freezer, do it 5 years later. Neutrophils don't do that. So to do any fancy testing, you can't really use neutrophils. So you have to find other ways to test for it. Because normally you'd like to look to see if there are antibodies on the neutrophil. You can't do that. So the test, just because of how neutrophils they love being inside the body, that it's hard to test. So it's not the best test. To work up autoimmune neutropenia, one is that, the degree of workup is kind of like how consistent clinically is it? Meaning you're presenting at the right age, neutrophil, you look great, you're not getting bad infections, you're not getting a lot of mouth sores. And you've kind of ruled out other causes. And that doesn't necessarily mean you have to do a bone marrow and all this kind of fancy testing, but there's nothing nutritionally there. There's no medicines that could be causing that. All the other blood counts look fine. Sometimes physicians will stop at that. And then some physicians, I think it's becoming more common to just do genetic testing, because in the past, it used to be when I was training, like everyone got a bone marrow. But now it's like, well, everyone gets genetic testing. So much less invasive. I typically don't, I'm not a big proponent. And again, every physician is going to tell you a different answer. I should have said that at the beginning here, but I'm getting less and less enamored with bone marrows, just because they, obviously they look painful. And for those of you who had them, I'm sure they are. And two, we can do a lot with genetic testing now to kind of rule out the bad stuff, because that's really what you want to do when you present with neutropenia. You want to make sure you don't have a congenital disorder or something bad. And we can do a lot more of that in the blood now. But to the benefit of getting antibody testing for neutrophils, I'm not a big fan of that, but some physicians are, just because if it's positive, it doesn't mean you have it because it's a bad test. And if it's negative, it doesn't mean you don't have it. I think it's more important to make sure, hey, you have a neutrophil count of 200. I need to make sure you don't have, Elaine neutropenia or some of those other disorders, which we can do at gene testing.
And a good follow-up question to that, this individual asks, do you recommend genetic testing to families who have a positive gene panel for neutropenia? Do you find that families will proceed with genetic testing for their whole family?
Yeah, absolutely. Now that's easy for me to say because, now some of the neutrophil disorders, particularly the ones that I went through, are not going to be very hidden, the ones that I presented there, but some of them, may look different, because I think sometimes when a family member says, well, you're very sick, you're in the hospital a lot, and I don't have that, but, like look at GATA2, that's a really good example. Some of those patients don't get sick until they're much older, and some get sick when they're really young. And that's autosomal dominant, meaning that if you have it, there could be other, many people in the family that have it. It's important for a couple of reasons. One, obviously it knows who's at risk. It helps us understand the disease a little bit better. And obviously it's important for the people who ultimately have it and may pass it on to other family members. That being said, to the point that you raised, is that it is I would say in a lot of situations, not most of the situations, when I have walked through that with families, there's an incredible hesitancy of family members to get it. And it's usually not cost, because the cost it's not minimal, but it's usually, doable. But if I think, people, which I could imagine is they don't want to know if they have a genetic disorder or not. So there's a lot of hesitancy that I've seen in families, despite the patient or the patient's parents really wanting to help out their family members, but the family can be resistant to do that. But I would, I think it's definitely needed. Just because they're not affected by that doesn't mean they don't have it. It could be that they have a genetic disease that may not manifest until they get older. And certainly for GATA2, again, using that example, there are things that we do now to prevent them from developing complications. A lot of them are put on azithromycin. Some of them are getting immunoglobulin replacement, just to kind of prevent infections and inflammation.
Thank you. And I think we'll get through 2 more questions, and then we'll have to start wrapping up. All right, this individual asks, how do you recommend directing physicians unfamiliar with neutropenia etiology and treatment to appropriate information, say if you're speaking with a hospital resident or a surgeon?
Yes, these are great questions. So I think you need to be, first of all, I think most physicians are very comfortable hearing those discussions and the concerns that you raise. I think sometimes patients feel if they raise that question, like that they're going to upset their doctor. And sometimes you could have complete faith in the doctor, but these are rare disorders. And not every physician is going to be, and most physicians are not going to be experts in your condition potentially. And depending on where you're at, it can be hard to find, physicians who are. And, a lot of the congenital disorders, you might be able to find a pediatric doctor, but it might be harder to find an adult physician. So I would open up the conversation. Having good communication with your physician is key when you have a chronic condition. Because that's going to build up your trust and make sure that you're getting the care you needed. So definitely open up the conversation. If your physician is honest and they're having, we're happy to work with physicians all the time. And one easy way to make those connections, it's not like, you can type in neutropenia in Google and find the right answer. But, between the IDF or the NNN or even the SNER, like those are great contacts to reach out to them. And you can, and you can tell me, Emma, like how they can connect with the IDF because you guys have connections. Oh, like we know neutropenia doctors in your area. And usually what I do, because I see adults too, even though, I'm a pediatrician, but, what often I'll do is like, if there's somebody who needs to be seen, because I have an area of that expertise, is what I tell the doctor, it's like, I'm not an adult doctor. I will see them. I'll give you advice as a consult, and maybe I'll see the patient once a year, but I want you to manage the patient. And it's a great relationship, because they can manage all the stuff I can't, and I can help them out with that one piece. So I think us as neutropenia doctors, we like to help, whether it's a phone call to the physician or a visit, but, we're not into, kind of having you travel, 3 states away to see us. I think there are other ways to do that.
Thank you. And we'll close out with this one because several folks are asking about it. Have you seen severe exhaustion with your chronic neutropenia patients?
Yes, I have. And I think this was kind of relates to the kind of the question about mental health. Yes, I see it a lot, and more in my adult patients that I kind of consult upon. And I wish I had an answer to do that. My feeling is that probably a large part of these chronic neutropenias are because the immune system is doing things that it shouldn't do to drive that. And even if you get blood work that says, well, we can get blood work to look at signs of inflammation, but when you have really low levels of inflammation, those tests are not going to be positive. And so I think I think it's definitely real. I think it's, fatigue is really hard to understand at a physician level because it's not like we like a test, right? We can send a fatigue test and says, oh, your fatigue level is this. And I'm sure you communicating to the doctor is hard. And, because when I see fatigue in my patients, and I'm sure your physicians have done this as well, is we look at everything, right? Thyroid problems, other endocrine problems. Are you anemic? Is there chronic infection? We kind of go through the workup, and often in my experience, the majority of cases, it's all normal. But the fatigue is very real and severe. I've heard patients say, like, I'm tired all day long and I just help me do this. And I wish I had solutions and how we can help with that. And how that, again, but when I say this, I don't think the neutrophil count being low is causing it. I don't think that is. I think it's some other component that might be causing the neutropenia plus the fatigue. And one thing to always think about is that the immune system. But again, a lot of this stuff I'm saying is very hypothetical because we just don't know. But yes, that is an unfortunate complication of chronic neutropenia, which we don't have a great handle on and certainly need to address to a better level.
All right, well, thank you so much, Dr. Connelly, and I apologize that we couldn't get through everyone's questions, but we are about 20 minutes over, and I don't want to take up too much more of Dr. Connelly's time. If you need to jump, fully understand. Thank you so much for everything. And we have just a few more slides to get through with some resources, everyone, and then we will wrap up. So we hope you will remember to take advantage of all of the resources that IDF has to offer. If your question didn't get addressed during the program, which I know we did not get through all of them, you can go online and submit your question to Ask IDF. Visit www.primaryimmune.org/ask-IDF or give us a call at that 800 number at the top of your screen, and someone will answer your question promptly. To find our materials on chronic neutropenia, you can visit primaryimmune.org and search using the toolbar, or you can visit the IDF Resource Center, where you can find videos of every IDF education program and countless resources. Here is a preview of some of our upcoming programs in the next couple of weeks. We have our first IDF webinar of the year, which will take place on Thursday, February 16th at 7 p.m. And next month, we have a SCID Compass Lunch and Learn on Wednesday, March 22nd. Be sure to follow us on social for the latest news and updates. We also have an upcoming state advocacy workshop in Austin, Texas on February 22nd, if we have any Texans on the call. No previous advocacy experience is required, and you can register to participate through the IDF calendar of events linked at the bottom of your screen. Before we go, we want to thank X4 Pharmaceuticals again for their generous support of today's program and many other initiatives at IDF. Thank you so much again to Dr. Connelly for being a part of today's program. Thank you, X4 Pharmaceuticals, and thank you all of you for joining us today and for your participation and engagement with the Q&A. We really appreciate it. Thank you so much, everyone. Have a great rest of your day, and we'll see you at the next IDF event.